Thank you, Mr. Chairman, and I'd also like to thank the organisers, particularly Dr. Mardikar, again for the invitation to be here, and also for the ESC. This is a slightly esoteric title, but hopefully it will become clear as I progress through this talk. I have no relevant conflicts of interest with regards to this. If you look at diabetes mellitus, it is a growing epidemic. The World Health Organization estimate there are 170 million patients worldwide with diabetes, 24 million alone in the USA, which is 8% of the population. And the World Health Organization estimate that this will double by the year 2030. If you have diabetes, it results in a 4 to 6-fold increase in adverse cardiovascular events. Diabetes is present in 25 to 50% of patients undergoing CABG, depending on what country you're in, and up to 30% of patients with acute coronary syndromes. And in diabetes, 75% of deaths and 80% of hospital admissions are cardiovascular system related. It's also important to note that if you have diabetes, you have worse short and long-term outcomes after coronary artery bypass grafting. This is data from the United Kingdom registry between 2004 and 2008, when we performed 114,000 CABGs, and we have a very strict reporting system in the UK, so we know the outcome of every single CABG operation. And what you can see is over that period, the overall mortality was 1.8%, and in elective patients, just over 1%. But you can see that the presence of diabetes increased your mortality by around 1% in those almost quarter of patients with diabetes. But also, if you look at what happens over the longer term, you can see that if you undergo bypass grafting and you do not have diabetes, you have a 90% 5-year survival, and the presence of diabetes drops that to 85%. Now, this was a paper published looking at the effects of on-pump and off-pump bypass grafting in patients from the Barry 2D trial. And these authors reported that the results of CABG were inferior in patients with diabetes when it was performed as an off-pump rather than an on-pump procedure. Now, I was asked to write an accompanying editorial to that, and as Dr. Gersh mentioned in his talk, it's quite interesting how easy it is to get trials wrong. Because what this study actually showed was that the 30-day MACE rate was significantly lower with off-pump CABG in patients with diabetes, whereas the long-term MACE rates were significantly higher with off-pump CABG. But what the authors failed to address was the fact that off-pump surgery had been performed predominantly in developing countries where there was much lower use of optimal-based medical therapy. In fact, the reasons these patients probably did worse in the long term were it's substantially inferior medical therapy. Because we know clearly now the difference between on-pump and off-pump CABG, at least in low-risk patients. This was the coronary trial published in the New England Journal of Medicine in 2013. I was one of the authors of this. This looked at 4,752 patients, and unlike all the previous trials of on and off pump surgery, the surgeons had to have demonstrated appropriate experience. In other words, they had to have done at least 100 bypass operations. But you can see that 82% of the patients had a Euro score less than 5, and the mean number of grafts was 3 off-pump and 3.2 on-pump. And if you look at both 30-day and 1-year outcomes, either the primary outcomes as a composite or the individual components of death, MI, stroke, new dialysis, there were no really any significant differences between on and off-pump surgery. So we know that for most patients, you can do off-pump surgery as safely as on-pump without any detrimental effect. However, as Dr. Gersh also alluded to, there are differences when you look at registries. There have been this is the largest propensity match registry comparing on and off pump surgery. It included 38 studies with over 120,000 patients. And these authors reported that off-pump surgery does lead to a significant reduction in mortality, stroke, renal failure, the need for prolonged ventilation, the need for balloon pump support, inotropic support, incidence of re-op for bleeding, blood transfusions and wound infections, and they concluded off-pump surgery does reduce all-cause mortality and morbidity. So again, a difference between what we see in trials where the patients were relatively low risk and what is happening in the real world. Now, I mentioned this earlier, that if we're ever comparing the efficacy of PCI or CABG in any situation, but today I'm going to do so for diabetes, the 4 questions we must always address are: were the patients enrolled in the randomized trials typical of routine practice? And as I explained earlier, with the single exception of the Syntax trial, the answer is usually no. There must, I argued earlier, be a minimum follow-up of at least 5 years, because you see a continuing survival benefit and reduction in MI and repeat revascularization the longer you follow CABG patients. We should have some idea of the Syntax score, because that gives us a good idea of the severity of the coronary artery disease. And I pointed out early this morning that there's several good studies now showing that CABG patients in particular receive substantially inferior optimal medical therapy in comparison to PCI patients. So if you look at the first piece of evidence regarding diabetes, this was demonstrated in the final 10-year follow-up of the Barry randomized trial, published in JACC in 2007. Now, the Barry trial, the original one, included 1,829 patients, but that was only 12% of the total potentially eligible population. And of these patients, 353 had diabetes. But when you look at the severity of disease in the patients, only 41% had 3-vessel disease, only 30% had proximal LAD disease, and the patients all had normal LV function. And what you could see as you followed these patients out to 10 years, in the patients who did not have diabetes, there was absolutely no difference in survival between CABG and PTCA. But for those patients with diabetes, there was a 12% survival advantage in favor of bypass grafting. Now, what this also underestimates is that because the analysis was done on an intention to treat basis, it ignores the fact that 50% of the PTCA patients actually had crossed over to CABG, but were still analysed as only having received PTCA. In this second analysis, this is by Hilatki's group. This was a collaborative analysis of individual patient data from 10 randomized trials published in The Lancet in 2009. Overall, there were about 8,000 patients included, but again, the patients had largely low-severity coronary artery disease. 2/3 of patients had single or double vessel disease, all had normal LV function. Even so, at a median follow-up at 6 years, there was a trend towards a lower hazard ratio with CABG compared to PCI at 0.91, but it did not reach statistical significance in the overall population. However, if you look at the 1,233 patients who did have diabetes, here the hazard ratio for CABG versus PCI was 0.70, so a 30% reduction in mortality, highly clinically and statistically significant. And also, if you look at these survival curves, you can see that even at 8 years, there's a continuing divergence in favor of bypass grafting in patients with diabetes. If we now turn to the Barry 2D trial, this was published in the New England Journal in 2009, and I was privileged to be one of the, to write and co-edit an editorial with Bill Bowden. If you look at Barry 2D, it was a complex trial because it involved 2 randomizations. One was to optimal medical therapy versus prompt revascularization. And the revascularization was pre-specified to either be PCI or CABG, depending on the severity of the coronary artery disease. And the second randomization was to insulin versus oral hypoglycemics. Now, if you look at the PCI cohort with 1,605 patients, you can see that only 20% had 3-vessel disease and only 10% had significant LAD disease. So if you looked at the outcome of this cohort, who were then randomized to medical therapy and PCI, so there were around 800 patients in each group, you can see at 5 years there was absolutely no difference in death, MI, stroke, or the composite of that endpoint. If you look at the 763 patients who were pre-specified to CABG, you can see that 52% had 3-vessel disease, but still only 19% had proximal LAD disease. If you compare the cabbage outcomes to medical therapy, there was almost a 3% reduction in mortality, but that did not reach statistical significance. But the incidence of myocardial infarction was reduced by 50%, and the need for repeat revascularization, or the composite endpoint of death, MI, and stroke, were also significantly reduced, and these latter two with the asterisk were statistically significant. But again, by 5 years, 42% of the medical group had required revascularization, but again were analysed on an intention to treat basis. So if you look at the most definitive study in diabetes, it's the FREEDOM trial. We've already seen this from Dr. Gersh's slide. It showed that at 5 years there was an absolute difference in the primary outcome by 8% in favour of bypass grafting, but crucially an absolute difference in survival by 5.5% in favour of bypass grafting. And if you look at the survival curve, you can see that at 5 years it's continuing to actively diverge in favour of cabbage, suggesting that if you follow these patients up for longer, the benefit of cabbage may be even greater. And I show this if you look to the right-hand side of this slide. You can see that for the Syntax trial, there was a differing survival advantage. This shouldn't say MACE, this should actually read mortality. If you look at the ASSERT trial of 190,000 patients, the New York registry of almost 16,000 patients, all of these curves show the same thing, that as you follow the patients beyond 5 years, there's a continuing benefit of bypass grafting. If you turn to the Syntax trial and look at the diabetic cohort, which was 452 patients, if we compare cabbage and PCI, there was a highly significant reduction in MACE, all-cause death, cardiac death, MI, and repeat revascularization, again in favour of patients undergoing bypass grafting. Now, this is one of several meta-analyses looking at the effectiveness of PCI with drug-eluting stents compared with bypass grafting in patients with diabetes. And the key point you see here is that cabbage causes a significant reduction in overall MACE, but crucially, a significant reduction in mortality, MI, and the need for repeat revascularization, but at the risk of an increased incidence of stroke by 1.5%. The authors also point out that the benefits of surgery continue to increase with time. This is a second analysis comparing PCI and cabbage in patients with diabetes. This time it was 8 trials with almost 7,500 participants, of whom 3,600 had diabetes. It involved 4 randomized trials using bare metal stents and 4 randomized trials using drug-eluting stents. And they concluded at a median follow-up of 5 years, cabbage had lower all-cause mortality versus PCI, with a risk ratio of 0.67, and they pointed out there were no differences in outcome whether PCI used bare metal or drug-eluting stents, and their conclusion was, in the modern era of stenting and optimum medical therapy, revascularization of patients with diabetes and multivessel disease by cabbage decreases long-term mortality by about a third compared with PCI using either bare metal or drug-eluting stents. Cabbage should be strongly considered for these patients. In a larger and more recent meta-analysis of 14 trials published in 2014, this now included over 7,000 patients with diabetes. And if you look at the mortality overall, and according to whether the patients came from randomized or non-randomized trials, they all showed a very significant reduction in the hazard ratio for death with bypass grafting, accompanied by marked reductions in MACE, target vessel revascularization, but again, at the risk of an increased incidence of stroke. And the authors pointed out there was a significant relationship between risk profile and benefits in mortality with cabbage, and concluded the present meta-analysis demonstrates that among patients with multivessel disease and or left main disease, cabbage provides benefits in mortality and TVR, especially in high-risk patients, but it is counterbalanced by a higher risk of stroke. Now, this is the most recent paper. This paper was entitled, "Has the difference in mortality between PCI and cabbage and diabetes changed over the years? A systematic review and meta-regression." And what you can see is that from the era of 1995, when it was predominantly balloon angioplasty, through to the early 2000s when it was bare metal stent, And over the last best decade, or best part of a decade, drug-eluting stents, you can see that the relative risk of mortality has not decreased even with the development of newer generation of stents. I've mentioned stroke several times, and this is the most definitive analysis of stroke in patients with diabetes by Athappan and colleagues, published in Stroke in 2014, looking at 7,000 patients with diabetes undergoing PCI or CABG. At 1 year, the incidence of stroke was 0.9% with PCI versus 2.3% with CABG. And at 5 years, those figures were respectively 3.8 versus 5.3. But I have to, again, emphasize the fact that the CABG patients received substantially inferior medical therapy, and the risk of stroke may have been lower in some of these patients, CABG patients, had they received optimal medical therapy. We already discussed this morning the 3 reasons why CABG has such a survival benefit over PCI. We explained that by placing bypass grafts to the mid-coronary vessel, it protects against the development of future culprit lesions. The benefit of an internal mammary artery eluting nitric oxide into the coronary circulation, demonstrated by Lucier almost 3 decades ago. And we also discussed why PCI often means incomplete revascularization in contrast to CABG. And for these reasons, I think, as I said earlier, PCI is unlikely to ever match the results of CABG for most patients with multivessel disease and for 2/3 of those with left main disease. What do the ESC-EACTS guidelines on myocardial revascularization say in patients with diabetes? They give a 1B recommendation that in stable patients with multivessel coronary disease and/or evidence of ischemia, revascularization is indicated in order to reduce cardiac adverse events. However, they give a 1A recommendation to the fact in patients with stable multivessel coronary artery disease and an acceptable surgical risk, CABG is recommended over PCI. It goes on to state, however, in patients with stable multivessel coronary disease and syntax scores less than 22, PCI should be considered as an alternative to CABG. That was given a 2AB recommendation. New generation drug-eluting stents are recommended over bare metal stents. That's a 1A recommendation. And finally, that bilateral mammary artery grafting should be considered. They give that a 2AB recommendation. So to summarize and conclude today, there is consistent evidence from randomized trials, meta-analysis, and propensity match registries that CABG, in comparison to PCI at 5 years, it results in better survival by at least 5% at 5 years. It reduces the risk of myocardial infarction by at least 50%, and it reduces the risk of repeat revascularization by at least 50%, but at the cost of a 1.5% increased stroke over 5 years. As I've said, maybe that could be decreased with better use of optimal medical therapy. I would also emphasize again that at 5 years, the survival curves continue to diverge, implying that the survival benefit of CABG will continue to increase with increasing duration of follow-up. On that point, I'm going to conclude my talk. I would like to thank the organizers again for the privilege of being here today, and you, the audience, for your attention. Thank you.